on the 14th.
Yep.
So they thought it was, for some reason, this was like only he would die on 3/14. And I'm like, what? I don't get it.
Now you have to get it. Yeah, right. Yep, Stephen Hawking, probably the world's foremost, well, formerly living physicist, a man who had amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, also known as motor neuron disease, but a disease that he was diagnosed with in his early 20s and given 2 years to live, and he lived to 76. Now, part of that was because, there are outliers, but the other is that once he proved his worth, he had lots and lots of medical care. But the issue is that it's a killer disease. I mean, very rarely does anyone live more than a few years with it. So he contributed a lot to our understanding of the physical universe, and he'll be missed. So, but he was an interesting character. A movie was made about his life a few years ago called The Theory of Everything, and the actor that played him did an unbelievable job. Just really, he nailed it. It looked like him, acted like him, everything. It was really, really well done. And the actor himself won an Oscar. So anyway, as I was telling Cheyenne before you came in, Glennis, yesterday or Monday, it was just Sarai and me. We discussed respiratory and dermatology. We talked about the respiratory system, talked about the various kinds of drugs. You do have an assignment, the week 2 assignment. You can download and fill out, and then just put it into the Dropbox. And it has to do with both of those, dermatology, respiratory, and today we're going to talk about cardiovascular. Going to do things a little bit differently with this lecture. Cardiovascular is a huge topic, but we'll go through a couple of things, and we'll do a couple of different approaches. We may sit down in front of my computer and watch a couple of videos. I will be recording all of this for Sarai, since she apparently isn't coming in today. We'll go through, I have a handout for both cardiovascular and the PowerPoint that I'm going to be using to talk from. So first off, I want to give the two of you these. The video of Monday's. It's posted in week 2. And today's class will also be posted there. So the cardiovascular system obviously is an important system. It's a complex system composed of the heart and the circulation, and it's connected very intimately, of course, with the respiratory system, since the respiratory system is where deoxygenated blood is oxygenated for circulation to the body. So the two are really interconnected, which is not to imply that other bodily systems aren't interconnected. All of our bodily systems are interconnected. So there's no, there's really no separation. So what I would like to try this morning is we have a video from Khan Academy on flow through the heart. And what I'm going to do is I'm going to bring my computer around and put it in front of you guys on this table here. and we'll watch that and hopefully get it recorded at the same time for the Zoom recording. So this is an experiment. So we're going to see if it works. Okay. Let's see what happens now. Oh, it would help if I turn on the sound.
So what you're looking at, your organs in your body, this is
Okay. So question, what did you think of that? What did you think of that particular video?
Maybe you've seen it one.
You probably have, maybe your AAP class.
Yes. We drew a big heart.
Yeah. Or have you taken Med 103 and ACG?
Yeah, because we took most of the parts, didn't we?
That's one place where you really study
Yeah,
why the heart works.
we studied.
Right, okay, so you study different heart rhythms. Okay, so among so this heartbeat should be very regular, should be steady. And the rate is all dependent on how much blood the tissues need, how much oxygen the tissues need. So if we are exercising, we're burning more fuel, using more oxygen, the heart starts beating faster. If we are not exercising, the heart's going to beat a little slower. Now, our couple of things go on. When the heart contracts, there is a surge in pressure in the arteries. That's what we measure when we do blood pressure. Both have, but you haven't had vital signs yet, right? When did you have it? No.
No, I haven't.
Yeah, I saw because I saw him giving you some instructions the other day about how to do blood pressure, which you can help us with. Mild help. And thank you for doing that. When the heart contracts, then pressure rises in the artery. When the heart releases, pressure falls. It never falls to zero. That's dead. Right? But we have two different pressures. So on the contraction of the ventricle. Good morning, Katie. On the contraction of the ventricle, you get a pressure squeeze. And when the ventricle relaxes, what we have is visual pressure of the movement to the arterial system. So the heart, and it should be doing this right, the rate of pumping is dependent on the body needs. Yes, ma'am. Somebody haircut.
Okay.
And I've emailed her already.
All right, just checking the back.
I know. It's amazing. Cheyenne was talking about how into the parking lot.
Spring break
Spring break at most of the schools.
yeah, so probably why.
Yeah,
You think we have,
you're welcome. No problem. So the rate is dependent on body needs. Now, blood pressure should be within a certain level. These vessels, these blood vessels, are designed to function under normal pressure. And remember the system itself, you go from the heart to the arteries, and then you go to the arterioles, and then you go to the capillaries. And these are increasingly smaller vessels, increasingly more fragile, really, because they're thinner. Okay? And under too much pressure, they can burst. Right? And when they do, it causes damage. But they're not likely. That's not unfortunately a really common thing. We're more concerned about things that maybe taken what is it? Med 280. Hematology. If you did the finger pokes and stuff, you haven't done that yet. There you learn a lot about the function of blood. Um, blood is moving through the body, fluid,
Yeah.
has many, many components. Besides cells, it has many chemical components. Those chemical components keep it from doing something that blood tends to do, which is clot. So what happens is this complex system is all dependent on the continued circulation. If blood begins to pool, and you see this, and we'll talk about that in a moment, if blood begins to pool in certain places in the body, it tends to clot. Because the anti-clotting factors get used up locally, and with no circulation, they're not fully distributed. So we have when the blood begins to clot within the body, those clots can block blood vessels, cause stroke, heart attack, so forth. And remember, there are two different kinds of event. In terms of stroke, we have what we call occlusive stroke, is when a clot blocks the vessel in the brain, or hemorrhagic stroke, which is what happens when a blood vessel bursts. And it can burst either due to very high blood pressure, or it can burst because the vessel itself is weakened. Vessels can have other problems, such as aneurysms, which are bulging parts of weak arteries. And when those burst, they can be very quick to actually kill you, depending on where. So there are lots of different things that go on. But notice that we have valves. One valve we did not mention was the valve out of the left ventricle into the pulmonary artery, which is a bicuspid. And again, he talked about a tricuspid. Remember, that's three flaps. Bicuspid is only two. And these are just membranes. And so the membranes are arranged so that they butt up against each other, so that if pressure comes in on this side, pushes them apart, and blood goes through, and when the pressure subsides after the bead is finished, they close up. And then if blood tries to flow back, it simply pushes them closer together. So problems can arise there. They get weak, they get fragile, they get hard, and they are sometimes, so sometimes we have problems with those. The heartbeat is controlled by a complex electrical system within the heart. And an electrical system in the body is not like what comes out of the wall. The electrical signals in the body, we call them electrical. We can measure them, but they're all chemically controlled. Okay? So it's controlled by a complex of these things. When the heartbeat is no longer running regularly, we call that an arrhythmia, meaning an abnormal rhythm. So the heart can have problems with that. Okay, it can have problems with the heart rate, arrhythmias occur. We can have problems with, for various reasons, having to do with complex chemical interactions in the body. Blood pressure is controlled by a number of different chemical systems within the body. We can have problems with one or more of those. Blood pressure is also controlled by volume. So one way of controlling blood pressure is to lower plasma volume with drugs that push fluid out of the body. Another point is that in traumatic injury, blood loss, you're lowering the volume of blood in the body. One of the reasons that one of the first approaches, one of the first things we do with And an injured person who's bleeding a lot, is we immediately start giving them fluids to rebuild their volume. Because when your blood pressure drops too far, the heart thinks it has to work harder. So it starts beating harder and faster. Well, the heart can only beat so fast before it becomes unable to beat controllably. We call that fibrillation. Okay? So the body senses that it's not getting oxygen. It tells the heart work harder, work faster. And when our blood pressure begins to drop, that's the condition we call shock. Okay? If blood pressure drops to 0, death results. But blood pressure can also be too low for too long, and shock can have some long-term problems. Okay, we're already a little past time when we're supposed to take a break. So let's take a short break, and 10 minutes. All right, so I've resumed the recording. We're going to talk about cardiovascular therapies. I'm going to give you actually a printout of the PowerPoint, and I'm going to skip sections of it. I don't need to go through the section through the heart. You just watch that video. So I will skip a few of those sections. We'll talk initially here, but I will jump to slide number 11, which is electrical conduction of the heart. The conduction system of the heart runs through nerves. The pacemaker of the heart is the sinoatrial node, which causes atria to contract. The impulse goes to the atrial ventricular node, and then spreads through bundles to the left and right of the heart, causing ventricles to contract. And we can read those on an EKG machine. The conduction works generally very, very well. The muscles function as a whole. So when the ventricle contracts, the entire musculature of the ventricle is contracting at once. If it's not, because of electrical problems in the heart, then we get problems with the way the blood is circulating. You've had the ECG class, so we won't go through much more of that. So remember what was said there. The heart is a pump. It pumps through blood vessels that have a limited volume capacity, limited because there is a definitive volume to the blood system, and we have it's controlled by various parts of the autonomic nervous system. The sympathetic nervous system affects the heart rate, and it increases the rate and force of the heart, and the parasympathetic nervous system decreases the heart rate. Blood pressure is regulated in a number of things. We look at the term cardiac output, which is the amount of blood that's actually pushed by the heart at any one beat. Blood volume and resistance. Blood pressure is composed of all of those. Resistance is friction within the arteries, and Quite frankly, what happens if the arteries begin to narrow because of plaque buildup or because of other changes that cause them to narrow? The resistance goes higher, and therefore it takes more pressure to push the amount of blood that's required to get through the system. So those are all important. Chemically important components of that are epinephrine, which increases cardiac output, blood volume, and resistance. Norepinephrine, the precursor to epinephrine, plays a role there because some of the receptors in the body bind better to norepi than epi. And then there's something called atrial natriuretic hormone, ANH, which is released by cells in response to stretch of the arteries. ANH dilates arterioles, which then decrease blood pressure and protect the heart from hypertension. Note that hypertension is always abbreviated HTN in notes if we're using abbreviations, but also remember that in a hospital setting, we don't use those in our records anymore. Another part of the controlling system is the renin-angiotensin-aldosterone system, which is based in the kidneys. So the kidney plays a role in blood pressure system. Renin, actually, if we think of what's the Latin term for the kidneys that we use, is renal function, right? So renin was isolated originally from the kidneys. The kidneys have a way of monitoring several things: blood pressure, blood volume, and the number of red blood cells, which are critical to, of course, to carrying oxygen. Decrease in blood pressure is usually related to a decrease in blood volume. So the kidneys will release renin, which then converts something called angiotensinogen, which basically is a precursor to angiotensin, to angiotensin 1, and then the enzyme ACE, angiotensin converting enzyme, converts angio 1 to 2, which is a very potent pressor, meaning an increase in blood pressure and it works by constricting arterioles. So it's a very complicated system. And it's a complicated system that also has lots of feedback loops to it in order to buffer it out so that no one part gets out of whack. When that does, we have changes in blood pressure, usually increases in blood pressure, and those increases can be treated if necessary. Blood pressure has been related to incidents of heart attacks and stroke. Blood pressure is an important factor. It needs to be ideally within a certain range. It used to be considered that if your blood pressure was above a systolic pressure of 140, then you were considered borderline hypertensive. Just over 140, between 140 and maybe 150. There is a lot of debate in the medical field as to whether or not that's the right level. Many are urging looking at controlling blood pressures that get systolic above 120, which simply, in my opinion, is really just an attempt to sell more drugs. Yeah. Yeah, there was some pushback on the 120. They're now looking at 130, but 130 is, they're calling that borderline hypertensive. My view is that if someone is running a blood pressure of 130, then what we need to do is monitor them rather than immediately start thinking about putting them on blood pressure medication. And monitoring. Because why does your blood pressure rise? Well, your blood pressure rises when your heart's working harder. Well, your heart might work harder because you just walked into the doctor's office after walking up 4 flights of stairs. You're going to have a higher blood pressure. So also blood pressure depends on not just activity, but to some extent on the time of day. My mother-in-law used to have to monitor her blood pressure every day and report the results to the doctor. And what I was urging her to do is always measure the blood pressure at the same time of day. Presumably, then she will have been involved in similar activities. And so we can buffer out the difference in the different kinds of activities during the day. She was also using one of these automated systems, which I don't like. I think it's much more accurate to be measuring with a person using a cuff and stethoscope. However, the automatic systems are fine if you don't have someone with you who can actually measure your blood pressure. So I get kind of annoyed when people are saying, "Oh, my blood pressure's up." Well, you know, and they're sitting at the blood pressure machine at the pharmacy at Safeway. Okay, and most of the stores will have those. So they stick their arm in there, and it's an automated machine. The machine, you know, we don't know what their baseline on that machine is because each machine is, you know, measures things differently. Theoretically, they're the same, but they're devices. So what we have is blood pressure really is a complicated system. We have, remember now, we've got renin, we've got angiotensinogen, we've got angiotensin 1, angiotensin 2, we've got aldosterone, which is angiotensin 2 stimulates the adrenal cortex to produce aldosterone, which then goes back and regulates sodium and fluid retention in the kidney, and thereby increases blood volume. Also, angiotensin 2 signals the brain of the need for water, thirst, in other words. So the whole to increase our volume. Angiotensin 2 also contributes to systemic vasoconstriction, in other words, narrowing of these vessels. So the whole system itself is extremely complex. The main diseases of the cardiovascular system are angina pectoris. Well, okay, pectoris really refers to the chest. Angina is pain, and it's basically chest pain. Chest pain from angina comes when the heart is not getting enough oxygen, often from some problem with cardiac arteries and the blood flow to cardiac muscle. Excuse me. It's treatable. Most of our treatments involve getting the arteries to relax, in other words, dilate. Because when they dilate, remember, more blood is going through, the resistance goes down, more blood goes through, more oxygen gets to the tissues. And things like nitroglycerin and related drugs like isosorbide dinitrate also will generate a chemical called nitrous oxide that actually dilates the arteries. Hypertension, elevated blood pressure, congestive heart failure is a catch-all term in some ways for the heart simply not functioning well. Coronary artery disease, again, a term that refers to a variety of conditions that can cause narrowing of our arteries and therefore impede blood flow. All of this is about impeding blood flow. We have myocardial infarction, MI, heart attacks, cardiac arrhythmias, and then a generalized term again, reduced vascular blood flow. Related to MI is stroke, the occlusive stroke. Myocardial infarction happens when a blood vessel in the heart is blocked by some material, usually a clot. Clots can come from various parts of the body. As we age, we often find that patients have buildup of plaque and other materials in a variety of places in the body, including some of the large veins, especially of the legs, for people that are not active enough, people who are not on their feet enough. These clots can move in and block small blood vessels, capillaries to arterioles, and basically prevent blood from flowing into various tissues. When tissues are deprived of oxygen for a relatively short amount of time, as little as 4 minutes, they start to die. Okay. So we treat many of these conditions with drugs. And one of the things you need to understand is that drugs mainly treat symptoms. They don't treat causes. Okay? So we use anti-hyperlipidemics to reduce blood cholesterol and other lipids. There is some, again, controversy now, some discussion now as to whether or not these drugs are effective and whether or not we should be concentrating and worrying about cholesterol. Antihypertensives, of course, treating blood pressure. What we call cardiotonics. Cardiotonics are a variety of different agents that actually regulate the functioning of the heart to treat heart failure. They include things like digoxin. Anti-anginals, I told you, nitroglycerin, isosorbide dinitrate, and a few other drugs that can be given orally or by injection. Anticoagulants to prevent clotting. Commonly, anticoagulants, they fall into a couple of different groups, and this is an area where intense research has been done for years. We'll talk about anticoagulants later. And antiarrhythmics that do things for irregular heartbeats. There are a number of different kinds of arrhythmias, and different drugs will treat different varieties of arrhythmias. These arrhythmias can be either regularly irregular. The heart, as you remember from cardiopulmonary ECG, the heart has what we call the normal sinus rhythm. in the way it beats. And that normal sinus rhythm has a very distinctive trace on an ECG readout. If the irregularity, the arrhythmia, is something that happens every time the heart beats, it might be an irregularity in, say, the QRS interval. If it happens on every beat, it's considered a regular irregular beat. If we have a lot of intermittent changes, nothing that happens on a regular basis, we call that irregularly irregular. So we have different kinds of things. We have flutter, which is basically the just heart is just beating with not very much force and very rapidly. Fibrillation is related to flutter, but it is, again, it's an irregular. The heart will beat real fast for a while, then slow down and maybe even stop briefly. Premature ventricular contractions. Okay, what happens is that the atria should contract and then relax before the ventricles contract. And the reason we want that is because the valves in between the atria and ventricles need to close. If the ventricle starts to contract early, then it shoves fluid back into the atria, shoves blood back into the atria. This can both lead to clotting, and it can damage the valves. Then we have the other thing about the fibrillations is that they're not efficient. They don't pump the blood out, so blood tends to pool in atria or in the chambers of the heart. And when blood pools, it tends to clot. So we also have rapid heartbeat, ventricular tachycardia, and ventricular fibrillation. Tachycardia is fast heartbeat. What's slow heartbeat? You remember that term? Bradycardia, right? Yeah, bradycardia. So there's lots of different ones. This is not an ECG class, so we're not going to go into the pathologies of these arrhythmias, which we can measure. We're going to look now at how we can determine premature ventricular contractions. Usually, we can hear this by what we call a heart murmur. And the heart murmur is hearing blood swishing back and forth when the ventricles begin to contract before the valves are closed. So there are lots of different anti-arrhythmic drugs. We have listing in the handout I gave you. We talk about some of these different drugs. Another term that is coming into use for to describe irregular heartbeats is dysrhythmia. Dys means inappropriate or wrong. Okay. Arrhythmia also means the same thing, but we're looking at how we can describe these things more generally, because sometimes it's not obvious what's going on. So we have drugs like the drugs that will slow cardiac conduction and thereby change the rate of beating of the heart and regulate it. We can use beta blockers like propranolol and atenolol and metoprolol, and quite a few. There are quite a few of these things. By changing the way epi and norepi are functioning within the heart, or working in the heart. We can block the flow of calcium in and out of cells. Calcium flux is an important part of cellular metabolism, and is an important part of regulating the electrical activity within the heart. So we can use various drugs for controlling that. Not just calcium, but potassium is critical as well. Remember, the body has a balance of potassium and sodium. Sodium is the main electrolyte in the plasma, and potassium is the main intracellular molecule electrolyte, which does not mean that they only appear in those places, but they enter the cells through pores we call channels. They're basically an opening in the cell wall that allows specific kinds of chemical entities to migrate in and out of the cell. So we have potassium channels, we have calcium channels, and blocking those can help change the repolarization after an electrical signal. And we use a number of those kinds of drugs, potassium and calcium blockers. We have drugs for treating atrial fibrillation. We can also use mechanical intervention on atrial fibrillation. If an otherwise healthy person, relatively, is having atrial fibrillation, we often will implant a pacemaker. And the pacemaker actually sends a little electrical signal into the heart to control the heartbeat and thereby limit the fibrillations of the heart. We also have drugs that we can use. Some of them are administered both orally and intravenously. We have drugs that we normally think of as sort of local anesthetics, like lidocaine. It can be used IV to control our premature ventricular contractions and other downstream effects. Okay. One of the things that has to be emphasized is that every drug that is used to treat arrhythmias can also, if used incorrectly, cause arrhythmias. So again, what we want to do is when we are a patient taking antiarrhythmic drugs, we want to be sure that we use them exactly as prescribed, because misdosing can cause other problems. Okay. Let's take a look. We'll talk about anticoagulants next. I mentioned implantable pacemakers. We also now have implantable defibrillators. You all know from your CPR training that a defibrillator sends a huge electrical shock into the heart to try and force it to work properly. We use it in CPR as an adjunct to compression and inflation. And remember that that we'll hook up if a person is not responding quickly to compression and breathing. We'll hook them up to a defibrillator, right? Remember that? We have small implantable devices. Defibrillators usually work on the ventricles because it's the ventricles that are pumping the blood to the lungs and to the body. So what happens is your pacemaker works at the atrial level. It actually stimulates the sinoatrial node. The defibrillator works at the ventricle level. So you can have an implanted defibrillator if you have ventricular arrhythmias. Ventricular arrhythmias are particularly dangerous, and usually they can rapidly lead to heart death. So what we want to do is control that. So we can have these things. These implantable devices, along with virtually anything else that is implanted into the body, require anticoagulants. In other words, the body's response is to try and surround whatever it is with some protective mechanism. Usually it includes also blood components and involves clots. So people who are having some of these, people who have bleeding problems in stomach, are often given anticoagulants, or I should say clotting problems. So anticoagulants prevent that. For many years, there were just a few products that were used for this. One of them being warfarin. Also given. Warfarin is a drug which reduces and inhibits the function of vitamin K. Remember, the clotting cascade for blood involves numerous factors, a number of proteins that are involved in this cascade of events that leads to the formation and later dissolution of a clot. Vitamin K is an integral part of that. So warfarin interferes with vitamin K and is an oral drug. The problem is that with warfarin is that if you are taking it, you need to have regular blood draws so that your clotting function can be assessed. We call it the INR, or International Normalized Ratio, which basically tells us how efficient your clotting mechanism is working. We use warfarin to reduce the clotting factors so that the body's not responding to these various things that are put into it. We have also injectably, we have heparin. Heparin is a complicated natural product which used to be strictly used in hospitals, but now we're actually sometimes sending people home and having them have a family member give them a subcutaneous heparin injection on a regular basis. And then we have the low molecular weight heparin, which is the product Lovenox, which too is an injectable product. Lately, we've had some newer agents come along. There are quite a few that have come out. Okay, I'm losing the names of them right now, but perhaps they're in our handout. No. They're not. Okay, the the newer agents like Eliquis, Xarelto, and a few others, Farxiga, have been developed in recent years. Oral agents that interfere with things like factor 10A, which is one of the major factors in blood clotting. And they have been being really pushed with the claim, which I am leery of, that you only have to check clotting factors once a year for patients taking these drugs. My problem with that is that these are all basically fixed dose drugs. You take some number of milligrams at the standard dose, whereas warfarin and heparin are individualized to the patient. And one of the reasons that they are is that, of course, every patient is different and has a problem. Also, warfarin, if you have an overdose of anticoagulants, what happens is you bleed. And sometimes the bleeding is uncontrollable. And with warfarin, if you have an overdose, all they have to do is give you an injection of vitamin K, and that will overcome an overdose of warfarin. These newer agents have no rescue. They have no rescue. There is one of them, Eliquis has one that's being developed, but last I heard, a year and a half ago, it had been rejected by the FDA as not safe and effective enough. So we have a lot of different approaches to preventing the formation of clots. Another form is drugs that prevent platelet aggregation. Aspirin, that's how aspirin works. Platelets form part of a clot. Remember, when you have a clot being formed, you have an injury, the first thing that happens is the body starts shoving platelets at it to try and create a plug. Platelets stick together when they do that. Aspirin makes the platelets slippery. And that's the best term that you can use, because the slippery plate, or the slippery platelet, will not stick together. So that's how aspirin works. That's why many people, especially older people, are urged to take an aspirin a day, or a baby aspirin a day, quarter of an aspirin a day. It will reduce the formation of these clots. We also, once a clot is formed, we have drugs that can dissolve it. We call these drugs thrombolytics. And the latest, the drug that is used mostly now for trying to dissolve clots in hemorrhagic, or in MI, or in occlusive stroke, is tissue plasminogen activator, TPA, also known as Activist. We use, or Activase. We use it quickly within 20 to 30 minutes after one of these events, and it can help dissolve the clot and avoid further damage. Another place that a clot can go is to the lung. And what happens is that the clot is called a free-floating clot is called an embolus. And when it enters the lung, if it's small enough to get through to get into the heart, usually these come out of a large vein like the femoral vein, where we have a condition known as deep venous thrombosis, which is a buildup plaque on the interior of the venous wall. And pieces of this can break off, go into the heart, go into the lung, and then it goes into the small venules and capillaries in the alveoli and block that off. I'm told that is very painful. We treat things like deep venous thrombosis with drugs to dissolve the clot. We also, this is one of the reasons that if you have a hospitalized patient, we'll put on compression socks with bed hose in order to regularly put pressure on the tissues of the lower leg to keep blood flowing. The way to reduce a deep venous thrombosis, which is the source of these emboli, which can cause not just pulmonary embolism, but stroke and heart attack, is to keep the muscles. The best way is to keep the muscles moving by getting up and walking regularly. If you can't, because you're bedridden, then these compression hose are what you need to continue to put pressure on the legs to push blood in the venous system back into the body. Okay, let's take our second break. We'll move on to anti-anginal drugs, and you can review those slides about the thrombolytics and anticoagulants on your own outside of class. So again, we talked about angina. It is something, it's a condition in which there is decreased oxygen getting to heart muscle. Obviously, heart muscle has to have a good, steady supply of oxygen to function properly. And when that's cut off, then the heart is still beating, but you start generating fatigue chemicals, and that causes pain. Also, it can be felt as pressure in the chest, but angina is a warning. It's a warning that that your heart isn't getting enough oxygen. So a method needs to be found for changing that. There are several different kinds of angina. Exertional or exercise-induced angina usually occurs when you are physically stressed, meaning exercising or perhaps doing something that that requires a lot of exertion. It could be working on a physically demanding job. Stable angina is the most common. And then we have some angina that can occur at rest. Stable angina is something that usually occurs under the same sets of conditions. Vasospastic angina is something that occurs at rest. And then there is unstable angina, which is something that is very risky, very dangerous, and is often a precursor to a heart attack. We use nitrates, as I said, nitroglycerin, isosorbide dinitrate, etc. We can also use calcium channel blockers and beta blockers to basically dilate the blood vessels. Okay. When the supply of oxygen or does not meet the demand, and so we have a negative oxygen balance, we call that ischemia. Ischemia is basically when we're having um, trouble, when we're having reduced blood flow, reduced oxygen. Ischemia can manifest itself in the heart. It can manifest itself in the brain. Um, I don't know if you've ever heard the term mini stroke. Mini stroke is also known as a transient ischemic attack. And a mini stroke, usually there's some minor impairment that's temporary. Transient means that there is a small blockage or great restriction of blood flow through a blood vessel, and usually it resolves. TIAs are not uncommon in older people who are already suffering from reduced functionality of most of their systems, and can be seen by behavioral changes or by give an example. A number of years ago, my wife and I realized that my father was having TIAs, and we diagnosed it by watching him walk, and one foot he couldn't pick up properly. We call it foot drop. It's when you lift up your foot and your front of your foot falls. And usually when you're walking and you pick up your foot, you're going to raise the front of the foot or at least keep it level. With a TIA, a lot of times you'll see this foot drop. That's an almost dead giveaway of what's going on. So we noticed that in my father, realized that his behavioral changes, he'd gotten just as nasty as an old goat. Were probably related to exactly that. Consistent TIAs can probably be dealt with small doses of anticoagulants. But the problem with TIAs is that they're not consistent. And you go to a doctor and say, my dad's having TIAs. The doctor doesn't see it. He doesn't trust you. Simple. With probably based on experience, he might not. He might not, should do. The way these vasodilators, the nitrates, work is because in their metabolism they release nitric oxide, which is a very potent vasodilator, and it dilates both veins and arteries, thus reducing the amount of work required to pump the blood and reducing cardiac consumption of oxygen because it's not working as hard. So they can be used to treat acute attacks or to prevent attacks. Other drugs, the way these things are used is, especially with nitroglycerin, we have patches. We also have tablets. The tablets are always given sublingually. Remember, under the tongue? And the reason is that the tablets are formulated so that as soon as they get wet, they literally disintegrate. Release the drug locally. It's absorbed through the oral mucosa. Remember, the oral mucosa is pretty permeable. And then immediately goes into the circulation. If you put it in and swallow it, what it does is destroy the nitroglycerin, and you just don't get any benefit at all. But even if you did, it'd be a half an hour. So what we don't want is for patients to be in pain for a long period of time. We also, with people who have a persistent form of angina, will give them patches, transdermal patches for these things. Other drugs can be used as well. There is a gaseous a substance known as amyl nitrite rather. You can use that in a nebulizer, or you can just break the ampule and have them immediately breathe the material. Works pretty quickly. You can read a little bit more about these, but we're going to move on to beta blockers. There are lots and lots of beta blockers. They all end with the suffix OLOL. So we got propranolol, atenolol, metoprolol, a number of these things. So what they do is they can change the rate at which the heart is working, increasing the rate, and thereby increasing the supply of oxygen to the body. As antihypertensives, the beta blockers are taken orally, and what they do is prevent the stimulation of heart cells by adrenaline, and so the heart rate stays normal, and the kinds of reactions that come from overstimulation, increased blood pressure and stuff, don't occur. They slow down the electrical conduction in the heart a little bit to allow the ventricles to properly fill and the workload of the heart to be reduced. We have lots of different things that go on with the use of these adrenergic drugs, but they have some side effects as well, always. So beta blockers will reduce heart rate, they will reduce the force of the contraction, and they will affect the AV, atrioventricular conduction. Side effects can include slowing the heart too much. They can also have other side effects. Calcium channel blockers are usually block the ability of calcium to get into the heart, and this also causes a decrease in the contraction of the hearts and dilates the arteries. When you do that, then the workload of the heart drops and blood pressure drops. They work in various parts of the body, both centrally and peripherally, to have their effect. The various drugs, there are quite a few of them, are used. The most of them get to this. Yeah. Okay. Most of them are used for control of blood pressure, but they can also be used for control of some of the arrhythmias. So side effects are listed here as well. We'll move on to congestive heart failure, which is the heart just basically can't pump properly to meet the metabolic needs of the body tissues. It actually has a habit of pumping less than it actually receives, so we get pooling of blood filling with fluid. When that happens, blood can accumulate in the heart, It can also accumulate in the lungs, leading to things like COPD, can accumulate in the abdomen and in the lower extremities. We call that edema. And it interferes with the ability of the patient to breathe. We use a series of drugs to treat this. One of the most common is digoxin. Digoxin is an ancient drug. It's a derivative. It's actually not a derivative. It's isolated from the leaves of the foxglove plant. We've been using it for 300 years. It's a well understood drug. It's one of those drugs, however, that has a very narrow, remember, therapeutic window, very narrow dose range from effective to toxic. Digoxin also is one of the reasons, by the way, that we have child-resistant packaging, because kids would get into their grandparents' medicine chest cabinet, find the bottle of dig pills, and they'd look like candy, and they'd eat them. Now, the side effects of this are pretty nasty. Fortunately, we can rescue. We have some pretty good drugs for rescuing overdoses. But nonetheless, that's one of the major factors that brought about child-resistant packaging. We can also use beta blockers like propranolol. Propranolol was the original beta blocker. It's still used extensively in its generic form. We can also use diuretics, reducing our blood volume and thereby reducing the workload of the heart, and vasodilators to, again, reduce the workload of the heart. Dig itself, it can be given IV or orally, and it increases cardiac output by increasing contraction force. It also slows the heart rate. So the contraction is stronger and the heartbeat is lower. Dig is used by many physicians, many cardiologists. I had a cardiology neighbor years ago who told me it was his absolutely favorite drug because it's, as I said, it's been being used for 300 years. We understand it very well. We know how to use it. And it also has the next advantage is, compared to its competing products, it's very cheap. A number of attempts have been made to displace dig from the drug armamentarium by other drugs. In every case, when you do a head-to-head comparison, dig is the better drug. So people are going to continue to use it for a long time. As I say, it's isolated from the foxglove plant. It's not something we can make in a plant. Overdoses can be treated either by supportive measures to keep the patient, keep the patient alive while the drug is metabolized out, or in severe cases, we have a drug that's really an antibody drug called Digibind that can be injected, and what it will do is bind up the digoxin in the plasma and allow it to be gotten rid of. Coronary heart disease, coronary artery disease is divided into a number of different areas. Atherosclerosis is when we also refer to as hardening of the arteries. Basically, what it is the arteries start to lose their ability, their elasticity, their ability to be stretched and contracted. This is often related to aging, so we often refer to older people who are having problems, especially mental problems, as having hardening of the arteries, which is a mistake, but we do it anyway. Or arteriosclerosis or we also have atherosclerosis, which is a buildup of fatty deposits called plaque on the interior, the lumen of the arteries. Okay. And when we talk about coronary artery disease, we're talking about both arteriosclerotic and atherosclerotic changes in the vessels that supply the heart with blood. This is why we have coronary artery bypass graft surgery, also known as CABG, for patients who have blocked coronary arteries. What we do with coronary artery disease is either find what happens if we don't treat it is often it leads us to MI, a heart attack. And what we want to do is sometimes use many of these buildups of plaque are related to lipid levels within the body. And several things that can be done. We can use drugs to lower the lipids, or if the coronary artery function is severely compromised, we do bypass graft surgery, which is taking a vein from some part of the body, usually the leg, and actually stitching it onto the heart artery upstream, in other words, in the direction of blood flow from the plaque, and then stitching it around that plaque to the downstream part so that the blood will actually flow around that blocked part of the artery. That surgery there are a number of coronary arteries, so you'll hear people talking about triple and quadruple bypass surgery, in which they're stitching these venous vessels around that many plaques on the heart. Cholesterol is a culprit in the plaque, and cholesterol has a number of different sources. Cholesterol is produced in the body, but we can also get it out of our food. It's stored in the body as either low-density lipoprotein, which comes out of the gallbladder, or high-density lipoprotein, which comes out of the liver. And both of these will be involved in these plaques. The LDL is stable and actually carries the HDL, the high density lipoprotein, is a stable molecule that actually carries the LDL cholesterol away from the arteries, thus reducing the amount of cholesterol that sticks. We call LDL the bad cholesterol, low density lipoprotein, and HDL the good cholesterol. And what we want to do is make sure that we have the right ratio, a good ratio of the two. We measure them both in serum, but we know that the function is for HDL to carry the LDL away from plaque and thereby reduce plaque formation. There are many discussions right now as to the real role of cholesterol. Obviously, we need cholesterol. You remember from A&P that cholesterol is an important component of cell walls, along with the long-chain fatty acids. Long-chain fatty acids are stored as triglycerides, another form that we measure. And we need to have a certain level of that in the blood. Too much of it, and it goes someplace. We talk about HDL and LDL as though those are the only two forms. There is a spectrum of lipoprotein in the body, and we're now finding that to properly characterize patients, we need to do a relatively expensive test, looking at the distribution of these lipoprotein particles of varying density. And we know that certain forms of hypercholesterolemia respond to drugs and certain forms don't. And that's predicted by that lipoprotein particle profile, which is about a $250 test now. We also know that some of the drugs just don't work on some populations. And when looking at cholesterol levels, here are the recommendations are that total cholesterol should be below 200 milligrams per deciliter. The LDL of those should be below 130 of the 200, and HDL should be at least 40 of the 200. To a certain extent, the more HDL, the better, but we don't want total cholesterol to rise above 200. Now, how do we control that? Diet and exercise are two of the things. A low-fat diet, but you don't want a totally lipid-free diet because we do need lipids. We also need exercise. Exercise helps blood flow, helps keep things moving, helps keep things metabolized and then excreted. And quite frankly, smoking is another risk there and should be avoided. Actually, it should be avoided anyway, for other reasons as well. But smoking is implicated in so many different things, and the reason smoking is implicated in lipidemias, dyslipidemias we call them, is because of its effect on the liver. The liver changes with smoking, and so we need to be aware of that. If we can't control it, then doctors are looking more toward using drugs. The various drugs that we have are in a number of different classes, one of which is actually listed here is actually 5 classes, but one of them has come under some understanding that it probably doesn't work. One is the statins. I call these HMG-CoA reductase inhibitors. HMG-CoA is a mouthful name, hexamethylglutarate coenzyme A reductase. So that's a big mouthful, but it's a specific mechanism of action of lipid metabolism. Those are the most popular. Statins don't work on a lot of people. For the most part, they don't work on women. It's been found. And over time, they don't seem to work that well on men. We have bile acid resins. We have these things often are used to absorb cholesterol. We have fibric acid derivatives. We have absorption inhibitors, and they list here niacin, vitamin B3. That's the one that has been really questioned lately. The data don't seem to support it. The thing about cholesterol inhibitors or anti-hyperlipidemic drugs is that they are absolutely not to be used in women who are pregnant or breastfeeding, because the developing first off, they'll cross the placental barrier. And the last thing you want to do is inhibit the ability of a developing fetus to form cells, which is, of course, cholesterol and lipids. So all of these are category X. And they also come out in breast milk. So obviously, a developing newborn, you don't want their cells inhibited. So we don't allow it. There's quite a few statins, and they work a number of different ways, and can work with with reducing cholesterol, and more importantly, increasing HDLs. We have one of the fibric acid derivatives, gemfibrozil, also known as Lopid. Decreases triglyceride formation. Triglycerides are the way our long-chain fatty acids are stored. And we have some others to lower LDLs. So there's a lot of different drugs that we try to use. They all have side effects, and the nice thing about them is that you can take them once a day if you need to have them. But you need to monitor your liver because, of course, where are they active? In the liver. The bile acid resins include things like questran, which is cholestyramine, but it does is basically, it just grabs on to lipids in the digestive tract and binds them up so that they're excreted through the feces. Okay. There are others that work as well. The absorption inhibitors basically interfere with the ability of the body to absorb cholesterol from the diet. Okay. Glynis, you have to leave in half an hour, right? Yeah. Okay. So, Cheyenne, I'm going to ask you a question. How about if we go until Glynis has to leave, then we take our last break? Does that work for you? Is that okay with you, Glynis, as well? Okay, so we're going to move on to heart attacks. Heart attacks are a major problem. Cardiovascular disease in general is one of the major causes of death in this country, probably the major cause of death in this country at this time. And they're usually caused by the blockage of a coronary artery, usually by a clot, an embolus. Once the heart cells are deprived of oxygen, they die very quickly, forming an area of dead material known as an infarct. And that's where we get myocardial infarction. There can be the patient, about 40% of people having a heart attack never make it to the hospital. They die before they can get there. Heart attacks can be can lead to death very suddenly, or they can heal. If we rescue the patient, the infarct area will undergo a partial healing, and is then and the body and the heart just recirculates blood to other areas for control, but the muscle is dead and it's just replaced with connective tissue. Problem with a heart attack is after you've had one, you're more likely to have another. And if you have one and survive, your chances of surviving the next one drop precipitously. Some people have several. And it depends on the cause. But the heart will weaken and very likely develop other problems in the future, either congestive heart failure or arrhythmias or other kinds of problems. The acute treatment is to take aspirin right away, preferably chew it up and swallow it. Yes, it tastes pretty nasty, but what you want to do is reduce the amount of time that it takes for the active ingredient, the acetyl salicylic acid, to get into circulation. You can take nitroglycerin to try and relax the heart muscles or the heart arteries and increase the blood flow. But we need oxygen and other kinds of therapies as well. One of the things that we do with heart attack victims now is we give them a thrombolytic, a drug that can break up thrombi. There is one that has been around for probably 50 years. It's called streptokinase. Streptokinase is a bacterial, obviously isolated from Streptococcus. The problem with it is that you can, generally speaking, you can use it once in a patient because since it's a bacterial protein, after that first exposure, the body will develop an immune response, an allergy to it. The other one, more recently, more recently is a relative term. It was developed in the 80s, is tissue plasminogen activator, known as Activase, and a couple of analogs that have been worked with. This is tissue plasminogen activator is a normal human protein. And so the theoretical position, and it's pretty much borne out by fact, is that patients can have multiple doses. So if you have another heart attack or stroke, you can use TPA for treating that. The way it works is it initiates in a very quickly the cascade of events that the body uses to resolve blood clots. When you have an injury and you have a scab formed, that's a blood clot. And the body can gradually just tear it apart without any further damage. And so that's what these things do. The effectiveness is pretty good, but it all depends on timing. You need to get to the patient quickly. They also have side effects. We'll move on to hypertension at this point. Hypertension is often considered the major player in cardiovascular disease. Hypertension is something that we have. There are many causes. There are dietary causes. There are physiologic causes. There are many sequelae, we call them, future events that occur because of hypertension. Sometimes we don't see it for 10 to 15 years. Hypertension, constant high pressure on the blood can lead to arteriosclerosis. In other words, the loss of elasticity of the blood vessels. Congestive heart failure, high enough pressure can result in hemorrhagic events within the body, in other words, burst blood vessels. If those occur in the brain, We call it a hemorrhagic stroke. These are the really nasty strokes that often just flat out kill someone or turn someone into essentially a vegetable, something that has, they're alive, but they have very little higher brain function. My sister's father-in-law had a stroke. This is now 35 years ago, I guess. Had a stroke. Actually, longer than that, 40 years ago. Had a stroke. And that's what it was called. But when we heard his symptoms, we pretty much knew it was a hemorrhagic stroke because he was paralyzed in general and had no higher brain function. And this was a man that weighed probably close to 300 pounds. And it took him 10 months to die. And in that time, he went down to 90 pounds because he couldn't eat. He had no function. So you don't necessarily just flat out die from these things quickly either, although my paternal grandmother did exactly that. She had a stroke and was dead within a couple of hours. So it can happen. Hypertension then is something that there's a couple of things you can do. You can look at lifestyle, diet, exercise. Smoking also raises blood pressure. So you can look at your lifestyle. Drinking also can do this too. Can also cause problems with blood pressure. So you can change your lifestyle. You can eliminate smoking because smoking anything is not good. Drinking alcohol, there's a lot of debate as to whether you should just do away with it entirely or reduce it down to something that's very much an occasional thing. But any of those can contribute to hypertension. We try that first, hopefully that'll work. If it doesn't, then chronic high blood pressure can lead to not just, remember, part of the blood pressure control mechanism comes out of the kidneys with the renin-angiotensin-aldosterone system. So kidney failure is something that can result, besides heart attack, arteriosclerosis, and stroke. Drugs are used to control it. We have a couple of things. We have a term, we define hypertension as blood pressure above 140 systolic and above 90 diastolic. Okay, that's a definitional term. This changes. As I said, we're now looking at trying to lower those. Should our blood pressure be lower? Probably. But we're talking about the real cause of major problems here. There's primary hypertension, which is linked to diet and lifestyle, and secondary hypertension, which can become from one of the internal mechanisms in the renin-angiotensin-aldosterone system. Many times we have no idea what the exact cause is. If we know that we cannot get patients to lower their blood pressure through diet, lifestyle changes, and weight loss, then we tend to look at drugs. Now, as a rule, I am not a fan of using drugs for chronic conditions unless it's necessary. But the side effects of hypertension are such that if we can't control it using non-chemical intervention, then I actually feel that the the benefits of lowering blood pressure outweigh the risks of the drugs. So I encourage that. But we have lots of causes. One of them can be sodium overload. This is especially a problem, apparently, in the African American population. They seem to be much more susceptible to sodium overload than others. Renal disease can affect blood pressure. Remember, the function of the kidney is to monitor volume and sodium and potassium levels. So when that can be an indicator of hypertension. There are lots of risk factors. Last week, I gave you guys the Framingham Heart Study. I hope you're working on that because it's due. I'd like you to bring it in on Monday so that I can grade that. The Framingham study is a large, long-term study. It's been going on for decades in Framingham, Massachusetts, to look at the relationship between heart disease and age, gender, cholesterol levels, smoking, and blood pressure. Okay. Note that I didn't include exercise in that. Or diet. Those are much more complicated issues because what we're finding is that taking a 20-minute walk every day is probably just as good as going to the gym and working out. The object is to get the heart rate up, get the blood flowing, get some of these various chemical mediators metabolized out and controlled. Okay, but the Framingham risk study is something that we wanted to look at. Other factors that can be a part of this is a family history of heart disease. We do know that these things are heritable. In other words, they can be passed on from generation to generation. And age is a factor as well. So read the Framingham study information there, and become familiar with the study and what the data have occurred. Over the decades this study has been going on, they've developed a scale called the Framingham Risk Factor Scale. And what this is a level of risk of a major cardiac event, usually heart attack, within 10 years of the time the study, the data are taken. Now, again, this is all based on statistical analysis. That we know these things, we can line up the data and see that they're correlated. This does not prove cause and effect, but correlation is a means of investigating potential cause and effect. It's what has allowed us to understand the risks of diet, the risks of cholesterol, especially HDL and LDL, and the relationship between all of these and age and gender. There are gender differences that occur on the biochemical level, which is why some drugs work in women and some not. Types of drugs we use: diuretics, reduce the volume. Lasix is one of the hydrochlorothiazide is what Lasix is one of the oldest, and it's one of the ones that's a first-line choice. There are other diuretics. Beta blockers, such as propranolol or atenolol. Propranolol is not used in a lot of patients as much as atenolol, because you can take atenolol once a day. The other anti-adrenergic blocking drugs are like work by interfering with the centrally acting adrenergic receptors are used, and we have peripherally acting adrenergic receptors. Plus, we can use combined mixed alpha beta blockers. Calcium channel blockers, angiotensin II receptor antagonists, ACE inhibitors, angiotensin converting enzyme inhibitors, and vasodilators. All of these can be used to reduce blood pressure. We usually start simple, and then because blood pressure is such a complex interactive process, we'll start simple and then start adding other agents. So we usually start with a diuretic. Remember, volume reduction lowers blood pressure. The problem is that a lot of people, especially the elderly, don't like taking them because they have to pee all the time, which means getting up in the middle of the night several times. And they don't like that. I can't blame them, but they also don't like to have higher blood pressure. They don't want stroke and heart attack. So we'll add to that. We'll use a diuretic, and then we'll go to a beta blocker, usually starting with one of the old tried and true ones, propranolol or atenolol. And then we'll add ACE inhibitors on top of that, calcium channel blockers, angiotensin receptor blockers, etc. We'll keep adding to it. Very seldom do you see patients switching off of one or another. Long-term, doctors will try, I think, to experiment with their patients to see what works best with them. But since everybody's different and it's hard without expensive testing to have any idea as to what's going on, what doctors do is we have a protocol that we follow. There are diuretics work at the kidney level. There are a number of different places on the nephron that these drugs will affect. Sometimes we end up with a couple of different diuretics even, because we want to affect a couple of different sites on the nephron. But you remember the nephron is a tube that we have a distal, the loop of Henle, and we have a proximal tubule. Drugs will act at one of those sites. There are drugs that work by selectively reducing the electrolytes. We have potassium-sparing diuretics. Potassium, one of the side effects of the general diuretics is that we lose potassium, and potassium, remember, is critical for intracellular function. So when we do that, we're sucking potassium out of cells, and a lot of times then we put patients on potassium supplements. Instead, it'd be better if they were put on a diuretic that did not reduce potassium very well, like spironolactone. So there's a whole series of slides here that look at these different kinds of antihypertensive drugs. We have vasodilators, and as well that can help. And we have alpha blockers that act peripherally to affect the adrenergic system. Guidelines periodically come out and change the way doctors, the recommended way doctors have looked at hypertension and at dyslipidemias. There are the guidelines include recommendations of specific drugs, and the avoidance of others. New guidelines come out periodically. The basic of all of our research is geared toward improving the effectiveness of drugs on the cardiovascular system. And there's a lot of changes periodically. So it's one of those things that if you're working in a cardiology setting, that you should keep a close eye on the new developments. Okay, so Glennis, we're going to stop here for now. We'll take a break and then we'll come back and Cheyenne and I will continue the class. And we'll probably watch some of those other videos. Let's resume the recording. All right. All right, I'm going to move this over here again. We'll just do this way. We'll watch these videos afterwards. Okay. So, first video that we're going to watch right now is we'll bring that up. Run it. See if we can.
I am going to present.
Pretty intelligent patient. You're welcome. Well, there's a lot of good information there, but they packed a lot of it into a small package.
Yeah.
And it actually pretty good. But let's share. And now let's go back, because I'd like to pick up I said back to. Gonna pick up AFib. Okay, atrial fibrillation. Here. Share. Share. And play. This is about atrial fibrillation. This video is unavailable. Well, we're not going to watch it. Good enough. We'll try the beta 2 out. We'll see if this one works. Obviously, it's fun.
Beta 2 alpha.
Okay, well, that was quick. That's fine. We'll go back now. And we'll go back now and look at, not bronchitis. What do I want to look at? Okay, these are obviously related to the respiratory material, so we're going to look at bronchitis next. No, we're not. So we'll go back now and see what else is available. Obviously, this didn't transfer very well. Okay. All right, this probably is going to work. Okay. So I can't watch this one because it can only be watched on YouTube. So you may want to look at that. Know exactly the let's try that. See what we get. Okay. And let's play this. Pardon? Oh, that's an ad? Okay. Sorry about that. I wasn't paying close attention. No. That I did not mean to do. Okay. No, that didn't work. So we'll do that. And now we'll play this.
No, starting on the video.
Yeah, it's gonna start. Let's see if we kill that. Okay. So we'll go back now. Go back here and see. We've got one more, I think. Let's see if that works. Well, we'll find out in a moment. Well, we'll have to watch it on YouTube. This time I won't mess with it. Looks familiar, huh? Let's see what they had to it. Okay. So cut that off. Alrighty. Now we'll go back. Maybe we'll try and see that other one and see if we can the AFib. Unavailable. Let's see if it comes on at all. Ah, I see. Well, here's one example of why people should be careful what they put on YouTube. So we won't be watching that. Questions.
Mm-mm.
Okay. So, well, maybe you should be talking about it.
They yell at me all the time because I don't use my inhaler. Because I was 10 before they finally said I had childhood asthma. So I just learned to cough it out. Fine. So I don't use my inhaler. I'm thinking about asking if I can get a nebulizer because that seems to help me a lot better than an inhaler does.
Well, the advantage of using
I saw that it helps.
yeah, it helps. Long term, it can be very beneficial.
Because it doesn't help me when I'm coughing. If I'm coughing a lot, I try to use the inhaler. Just makes me cough more.
Well, then you probably just need to work at using it regularly.
Yeah.
That will reduce that reaction.
Yeah.
Okay, so this week we have the premium risk assessment and we have the and dermatology assignment determined. You also have what else are we doing?
I need to
A discussion. You've already done your discussion.
do the antibiotic injection.
Right. Get that done. And there's a quiz.
Okay. I'm typing it because I can't get all this in the box.
Right.
I'm typing it. And then I'll print it.
Okay. That works. So get that as quickly as you can. And that's about it. If you have no other questions, maybe we'll close this out earlier. So Diane, if you are watching this, and I'm going to send you an email. The way that I will know you watched it is if you send me an email, and if you include in the email the word Lugano, Lugano, then I'll know you've watched this video, and I can give you a point for the class attendance. So, other than that, try to get the work done, and we'll cut this. We'll end this as it is. Okay. So there we go.